This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Journal of Korean Medical Science, published in 2026. It's titled Single Fraction Stereotactic Radiosurgery for Benign Perioptic Meningiomas, a strategy for long-term tumor control and radiation-induced optic neuropathy avoidance, with a 10-year follow-up.
This is a crucial topic, Alara. For years, perioptic meningiomas, or POMs, have been a bit of a no-man's land for single-fraction radiosurgery. When a tumor is sitting right on the optic apparatus, the fear of radiation-induced optic neuropathy, or RION, often leads us to underdose the tumor. We've lacked that really long-term data to know if our caution is actually hurting the patient in the long run.
Exactly. Most studies give us 3 to 5 years of follow-up, but as we know with benign meningiomas, that's just not enough. This study out of Seoul National University Hospital specifically looked at patients followed for more than 10 years. The median was actually 152 months.
That's over 12 years of median follow-up. That is gold in our field. Now, let's get into the specifics. How did they define perioptic for this cohort?
They were quite strict. They only included patients where the tumor was less than 2 millimeters from the optic apparatus, which includes the optic nerve, the chiasm, and the optic tract. They looked at 30 patients who underwent gamma knife surgery between 1998 and 2010.
And for our residents listening, that 2 millimeter distance is the classic danger zone, where the dose gradient of the gamma knife is put to the ultimate test. Ilara, walk us through the treatment planning. What were they aiming for?
They used a specific rule for their prescription. When the patient had functional vision, they aimed to keep the maximum dose to the optic apparatus, the Dmax, below 8 gray. If the eye was already blind, they were more aggressive with the tumor dose. On average, the gross tumor volume was about 4.8 cubic centimeters, and the mean dose delivered to the tumor was 12.7 gray.
But here's the catch, right? If you're keeping the nerve under 8 gray, but the tumor is touching that nerve, you can't wrap the 12 gray isodose line around the whole tumor.
Precisely. That's the central conflict of the paper. Their mean coverage rate was only 77.7%. That means nearly a quarter of the tumor volume was receiving less than the prescription dose to protect the optic apparatus. They also looked at the D98%, which is the dose covering 98% of the tumor, and that was only 7 gray.
So they were essentially undertreating the margin closest to the nerve to stay safe. Let's talk about the results. Did that safety-first approach work for tumor control over 10 years?
Well, the 5-year progression-free survival was actually quite good at 90%, but this is why long-term follow-up matters. By 10 years, the progression-free survival dropped to 70%. Overall, they achieved tumor control in only 57% of cases.
That's a significant drop-off. It suggests that these tumors aren't being cured, they're just being slowed down. What was the timing of the failures?
The failures occurred in a very delayed fashion, on average 107 months after the procedure. Some failures happened as late as 200 months post-SRS. The most important factor they found for long-term control was the coverage rate.
Did they find a specific cutoff value?
They did. A coverage rate of 81% was the statistical threshold. Patients with more than 81% tumor coverage had significantly better long-term control. When coverage was sacrificed to protect the nerve, the tumor eventually regrew in that underdosed shadow.
This is the classic neurosurgical dilemma. We're trying to avoid a complication, RION, but by being too cautious, we're allowing the disease to progress. Now, let's talk about that complication. Out of these 30 patients followed for over a decade, how many actually developed radiation-induced optic neuropathy?
This was the most striking part of the study. 0. There were no occurrences of RION in this cohort.
0? In 10 years?
None. Among the patients with functional vision, the mean Dmax to the optic apparatus was 7.2 gray, with a range up to 12.9 gray in some cases. Even with those doses, they didn't see radiation damage. They did see visual decline in 2 patients, but when they looked at the imaging, it wasn't from radiation. It was because the tumor had progressed and was compressing the nerve again.
That is a powerful aha moment for the listener. We spend so much time worrying about the 8 gray limit for the optic nerve, but this data suggests that for perioptic meningiomas, the real threat to vision isn't the gamma knife, it's the tumor itself regrowing because we didn't cover it adequately.
Exactly. The authors point out that inadequate tumor coverage near the optic apparatus, driven by concerns about RION, resulted in a significant incidence of long-term tumor progression and subsequent visual deterioration.
Let's dive deeper into the dosimetry for the residents. They used GTV and a newly established GTV for their analysis, right?
Yes, they actually went back and revised the tumor contours for the study, creating a new GTV that included things like the dural tail, or portions of the tumor that might have been omitted in the original 1990s or 2000s planning. When they reanalyzed the dose volume histograms with these more accurate contours, they found that the coverage was even lower than they initially thought.
It really highlights how precision in contouring is just as important as the dose itself. If you miss the dural tail, you're leaving a seed for recurrence. Now, Ilara, the study mentions that surgical decompression is still the primary approach for tumors in direct contact with the nerve. How does this study change our view on SRS as a first-line or adjuvant treatment?
The author suggests that while SRS is an effective alternative, we might be being too conservative. They noted that the safe dose for the optic nerve might be slightly higher than the traditional 8 gray limit, especially if a higher dose is needed to achieve that 81% coverage threshold. They mentioned that clarifying the optimal dose range is crucial for achieving sustained control.
It's also worth noting the era of this study. These patients were treated up until 2010. Today, we have fractionated stereotactic radiotherapy, which allows us to deliver higher doses to the tumor while exploiting the radiobiology of the nerve through fractionation. But for centers that only offer single fraction SRS, this 10-year data is a wake-up call.
It really is. It shows that if you choose single fraction, you have to be aggressive enough to control the tumor. If you keep the dose so low that your coverage drops below 80%, you're likely just delaying an inevitable recurrence 8 or 10 years down the line.
And for a 50-year-old patient, a recurrence at age 60 is a major problem. That's not a success in my book. Did the study mention any specific patient factors?
They analyzed various dosimetric factors, but coverage was the heavy hitter. They defined tumor progression as a volume increase of more than 20%. Interestingly, because the progression is so slow, patients might not even notice the visual decline until the tumor has significantly enlarged.
Which is why the biannual MRIs and annual ophthalmological exams the study used are so important. You can't just discharge these patients after 5 years.
Definitely. They followed some of these patients for over 23 years. That's the kind of dedication needed to truly understand the natural history of treated meningiomas.
So if you're a resident in the planning room today and you're looking at a 1.5 centimeter meningioma touching the chiasm, what's the take-home message from this Seoul National University study?
First, don't ignore the coverage. If your coverage is dipping into the 70s to keep the nerve at 8 gray, you are at high risk for long-term failure. Second, Ryon might be less common than we fear at these marginal doses. The study had 0 cases with a mean Dmax of 7.2 gray. And third, tell your patients that 10 years is the minimum follow-up, not the maximum.
Great summary, Ilara. It's a reminder that in neurosurgery, safe is a relative term. Being safe for the nerve might be dangerous for the patient's long-term tumor-free survival.
Precisely. The paper concludes that we need to find that optimal balance to prevent the very visual deterioration we're trying to avoid.
That's all the time we have for today. Thank you, Dr. Ilara, for breaking down this important 10-year follow-up.
My pleasure, Dr. Aris.
This has been the Neurosurgery Hub podcast. Join us next time as we dive into the latest evidence-based practice. Stay sharp.